dyspepsia, which we are going to mention later. Only 20 to 25% of patients with symptoms suggestive of peptic ulcer disease are confirmed to have peptic ulcer disease on investigation. What are the alarm features warranting Prof GI referral? If a patient has dyspeptic symptoms and presents with anemia or GIT bleed, that's an alarm feature. Early satiety could be an alarm feature, maybe some malignancy in the background. And so it's unexplained weight loss. Progressive dysphagia or adrenophagia needs a GI referral. Recurrent vomiting, and if there's a family history of gastric GI cancers could present with perforation, sudden onset of severe generalized abdominal pain associated with peritonitis. Usually there's perforation. Gastric outlet obstruction, the pain will be worse after meals. There'll be nausea, vomiting of undigested food, and patients tend to complain of fullness and bloating, and with association of nausea and emesis. And they may present also with bleeding. That's another complication. Other physical signs, epigastric tenderness, the predictive value is rather low. The physical signs are only of value in predicting ulcer complications, but not in predicting an uncomplicated ulcer. How do ulcer develops? There's usually a balance between protective mechanisms and aggressive mechanisms. Destabilized, then you end up with peptic ulcer. And these are acid, pepsin, bacteria, and drugs, the NSAIDs and aspirin-like drugs. Factors involved in gastrorenal defense and repair involved is at the pre-epithelial level. That's the mucus is there, the bicarbonate, surface active phospholipids. At the epithelial level, we have the cellular resistance, restitution, prostaglandins, and cell proliferation. Whereas at the subepithelial level, there's the blood flow and leukocytes. So there are three levels of defense: pre-epithelial, epithelial, and subepithelial. What about the aggressors? H. pylori is the most common in our environment and worldwide. NSAID and aspirin, common, and you do see them in Zolling-Ellison syndrome and also in some idiopathic cases. I think in our environment, you must make sure you rule out presence of H. pylori and history of use of NSAIDs and aspirin. What are other pathophysiological factors which you need to consider? Smoking may have some influence by reducing bicarbonate secretion. Remember, bicarbonate was one of the protective mechanisms involved. And it also increases the risk of HP infection and generates noxious mucosal free radicals, which could cause mucosal damage. So try to advise them to avoid smoking, patients who have got ulcer disease. But remember, acid secretion is not increased in smokers. It's only that there's this risk of interfering with the risk of HP infection. People think that there are genetic factors. It's not clear whether genetic factors play a role, but blood group O has increased affinity to H. pylori. So that way, maybe we could say, in a people with blood group O may have, if they're in family members and they have H. pylori within the family with same genetic composition, they may have peptic ulcer disease. Pulmonary diseases have increased acid production, and they tend to have increased peptic ulcer incidence. Alcohol is query its role. No clear documented association between peptic ulcer disease and diet or stress. Most people will ask you, what are you stressed about when you diagnose with ulcer? It doesn't really play a role. It plays a role in non-ulcer. Remember, H. pylori and NSAIDs are independent risk factors and also are synergistic, okay? So when you get H. pylori, when somebody is on NSAIDs, also look for H. pylori and try to clear both of take care of both of them. How do you investigate somebody suspected to have peptic ulcer disease? Imaging studies, when you were at your level, were the most common. This barium has gone down, but it is still an investigation modality where you don't have endoscopic services. Then endoscopy, the upper GI, is a gold standard. It's indicated in all patients with alarm symptoms, all gastric ulcer. Whenever you get them, you also have to biopsy them. Test patients for the cause, and H. pylori is a common cause, so you have to screen for H. pylori. It's a gram-negative spiral-shaped bacteria, or it could be acquired through fecal-oral and oral mechanism. They have tests for H. pylori. There's the non-invasive serology, the IgG antibody test. You can use it for making an initial test if the patient has never been exposed to H. pylori or has never been treated. But in practical purposes, we normally don't use it. Maybe if you're in a field, doing a field research, you could, but in day-to-day practice, specificity 83%. As I've said, it's not used in detecting success of treatment, and it takes long for the levels to fall down. Non-invasive tests which we use to diagnose H. pylori include urea breath test. We don't have that one in our country. In developed country, that's the most popular. And it has a sensitivity of 97% and a specificity of 96%. There will be some PPI for about 4 weeks before you do the test. If the patient needs acid suppression, then you could put them on H2 receptor or antacids. What about then? We have this tool for H. pylori antigen testing. That's the one we use here because it's cheap, it's readily available. It's a specific immunoassay using monoclonal antibodies for quantitative detection of H. pylori. A good sensitivity specificity of 96. Both urea breath test and stool antigen are used for initial diagnosis and follow-up. And patients should be off PPI for 4 weeks, but can continue the H2 receptor before you do the test to get an accurate result. Then we have the invasive test. If in case you are doing an endoscopy, then you can also test the patient for H. pylori using the rapid urease test, using histology. That's the one you need to remember. It's mainly for histology. Silver stain is mainly for the H. pylori organism. Gentle stain combines both. So one can easily view which one of these would detect both H. pylori organism and also give you the histological changes. The gentle stain would be the correct answer there. Also, in research purposes or in cases where there's problem with the response to treatment, you could do culture for sensitivity for routine purposes. Rapid urease test is the one you use when you do a gastric biopsy and put the substrate in a urea containing urea and phenol red. And if H. pylori is present, then there'll be a color change from yellow to red as it changes the pH. Therapy, H. pylori associated peptic ulcer disease. So in choice of antibiotic therapy, you should be guided with the risk factors for macrolide resistance in the area you are in, and the allergy to penicillins. Those should be critical. The risk factors for macrolide resistance include prior exposure to macrolide therapy for any reason, high local clarithromycin resistance more than 15% makes it not a choice of eradication rate of clarithromycin is also less than 85%. Again, that's not a best choice of antibiotic. So in that case, then you can either use tetracycline or metronidazole or amoxicillin in place of clarithromycin. So usually the treatment is a triple therapy. That's the standard treatment where you use 2 antibiotics with an anti-secretory agent. PI with metronidazole, clarithromycin, and so on and so forth. Currently, the duration is 14 days. If you read the old books, it may still tell you 7 days. And the medication should be given on a twice daily regime in terms of the triple therapy. Though in late there's increased resistance to clarithromycin of more than 15%. So in such areas, the eradication rate will be less than 80%. Public analysis done with one of the postgraduates last year has shown that in our area, the resistance, the resistance is less than 15%. So in that case, we can still use clarithromycin in our environment. Quadruple therapy is another in fact, international guidelines give quadruple therapy as a fast. So they say hit hard and clear it rather than hit low and don't clear. So here you have you are giving 3 antibiotics and a PPI, and the antibiotics are given as a QID, and then 4 times a day, and the standard antibiotics for quadruple therapy, if it is bismuth-based triple therapy, would be bismuth subsalicylate or salicylate, tetracycline, and give them at 4 times a day. It's not an easy regime, but it works very well. I use it quite often. Then you combine it with PPI. My most popular either esomeprazole or arabiprazole. Those ones tend to have a little bit higher efficacy. And we expect a eradication rate of more than 85%. It's, in terms of the international guidelines, it is a first-line therapy. 14 days is preferred. Therapy, give all drugs, give all these drugs, that's amoxicillin, clarithromycin, antinidazole, together with PPI, but this time it's as a BID dose. And they say you should just give them for about 5 to 7 days. But I don't find it very useful, this regime. Then we have the metronidazole-based therapies, preferred if clarithromycin resistance is more than 15%. Metronidazole and tetracycline. This one I think is too, you may not be able to read it, so it's just the things we have been talking about. Then third line or salvage regimes, you need to, possibly you could indulge into the role of culture and sensitivity testing and avoid using, avoid repeating the antibiotics you have used. Some people give same antibiotic 3-4 times in terms or kids. Remember, when somebody has had H. pylori, the first thing you need to ask is which antibiotics were in that kit. And if they didn't respond and they took it regularly, then you should not repeat the same antibiotics unless it's amoxicillin, which they still know, and tetracycline with persistent at the moment is still very low. Then we have the salvage therapies, which involve levofloxacillin with PPI and amoxicillin. The problem with levofloxacillin is that the respiratory people use it, but it is, in terms of international guidelines, it is a salvage therapy, and it has got a The problem is that resistance I'm talking about. And rifabutin-based therapies, the problem with rifabutin is also used in tuberculosis treatment, so we try to avoid it as much as possible to avoid resistance to it, but it could be used. Remember, the problem with rifabutin is marrow suppression and ocular toxicity. The resistance to amoxicillin and tetracycline are very low, so they are you could bet with them because there's very low resistance worldwide. While resistance to metronidazole and promethazine are quite do occur quite often, so you need to check on the resistance pattern in the area you are in. So though you may have resistance in terms of when their drugs are combined, you may find that there is no resistance at all. Then we have firazolidine-based rescue therapy, where you combine firazolidine, bismuth, tetracycline, and PPI. And as you can see, the cure rate is low, but this is now a rescue therapy. So those who, if you can again get 70% of those who had failed to now respond, it's still good. But if the side effects are headache and abuse-like reaction, hemolytic anemia. I've already mentioned that even if the in vivo resistance to metronidazole does occur, we still find it in vitro. It does work if you give it longer and at higher doses, particularly in quadrupotherapy. I've already mentioned the issue of resistance to clarithromycin, and so I don't need to, and also to metronidazole. The take-home message in terms of peptic ulcer treatment is H. pylori triple therapy, but check on the resistance pattern to clarithromycin in your area. If it's less than 15%, use it. Like in our country, it is still less than 15%. And PPI plus bismuth-based triple therapy is another good option. Okay. Second lines could be PPI, levo, and amoxicillin. And if it does not still work, you refer. Stop the NSAIDs, check for HP and treat, and put them on PPI and or esomeprazole. COX-2 and PPI could be used if some anti-inflammatory is required. Patients with dyspepsia, eradicate HP if present before commencing on NSAIDs. What about acid hypersecretory states-related peptic ulcer? In this case, then you see you need to give, these are, they'll have recurrent ulcers, and so you need to treat them full dose, and you may have to maintain them because the hypersecretory states continues. So that's the end for the for this talk, and so if there's any question on this one before we go to the next one, otherwise we go through them fast. What's the class rep think? Quite a bit of them, just a minute. Let me remove this. I think our next one was esophageal disease. Okay, so the next thing would be, we'll just highlight on GORD and digestive disorder characterized by chronic acid reflux American College of Gastroenterology defines it as symptoms or complications resulting from the reflux of gastric contents into the esophagus or beyond. That means beyond is the oral, into the oral cavity, including the larynx or lungs. And most common symptoms are typical symptoms are chronic heartburn and regurgitation. And we'll have at least one of them. What are the other symptoms you do come across in gastroesophageal reflux disease? In extraesophageal symptoms may include chronic cough, wheeze. They may present with, which tends to be worse at night because you are lying down and acid reflux is more. They may present with sore throat, hoarseness of the voice, secondary to laryngitis, and gum disease. Other symptoms which are rather atypical and not really reflective of reflux could be belching, gas and bloating, halitosis, sour taste at the back of the mouth, and global sensation and dysphagia. What causes GERD? Most cases of GERD are caused by a problem of lower esophageal sphincter, and when they leak up into the esophagus and cause symptoms like heartburn. What may be associated with problems with lower esophageal sphincter? Obesity. There's something in the, I don't know where it's from, in the screen. Okay. Obesity, overweight could predispose you to lowering of lower esophageal sphincter pressure. Fatty meals, this delays gastric emptying. Tobacco, alcohol, coffee, chocolate. So you may advise the patients to reduce the intake of those, as they could increase lower esophageal sphincter relaxation. During pregnancy, there's quite a bit of heartburn. This could be because of the hormones lowering the lower esophageal sphincter pressure, and also the effect of pregnancy. Presence of a hiatus hernia, that's now a mechanical defect. Connective tissue disorder, gastroparesis, and stress. So diagnosis could be from clinical symptomatology, therapeutic trial of PPI, endoscopy and biopsy, checking whether it's erosive or non-erosive GERD, ambulatory pH monitoring, esophageal manometry, or a combined impedance plus pH testing. But most patients, we don't need to go into those. Most patients, we just diagnose with a clinical symptomatology. They have heartburn, they have regurgitation, all the other symptoms which I mentioned. Then you give them a therapeutic trial. And if they respond, you know there is GERD. If they don't respond, then if there are no alarm, then you need to evaluate them. If they have alarm symptoms, then you have to evaluate them early. We'll come to that. And treatment involves lifestyle modification, acid suppression, endoscopic intervention, and surgery. I think that was just the little I put for you, because there are so many talks. So that's what I put for the, you'll have to read more on that. So we'll have to go to another talk. Let me remove this and go to functional dyspepsia. And what has happened? Sorry. Share screen. Okay. Functional dyspepsia and irritable bowel syndrome. We'll run through it quickly. We hope that within the next 30 minutes we'll be done so that we'll have done our 1 hour. Slideshow.
Professor, I just wanted to let you know that you have time till 9 p.m. So
9 p.m.
Yes. Sorry, 9 a.m. 9 a.m. Sorry.
You are going to
You
offer
can...
us virtual meals today.
Yeah,
Okay.
sorry.
Okay, fine. Okay, then that's okay. That's okay. Yeah.
Right.
So functional dyspepsia and irritable. We used not to give talks on this, but a few 2 or 3 years ago, I introduced it in your talks because you see a lot of these patients in your clinical practice, and in fact, they'll be the majority rather than the ones. So functional dyspepsia or idiopathic or non-ulcer dyspepsia, you could refer there, you'll find some places they are written as non-ulcer dyspepsia. It means the same thing, or idiopathic dyspepsia. Okay? And normally it requires exclusion of other organic causes of dyspepsia. And it is defined by the presence of one or more of the following: postprandial fullness, early satiation, epigastric pain or burning, and there should be no evidence of structural disease to explain the symptoms. So you have this, when you eat, you find you get full, and or you get satisfied before you have eaten much. You get epigastric pain, burning, which you cannot really, it's not, you have to think in terms of functional dyspepsia. Functional dyspepsia may be associated with motility disorders or visceral hypersensitivity. The motility disorders could be, you may be having delayed gastric emptying, or you may be having rapid gastric emptying, or the patient may be having antral hypomotility, or and impaired gastric accommodation in response to a meal. And as I've said, there may be visceral hypersensitivity also accounting for the illness. Now, when you have somebody who has got dyspeptic symptoms, you need to evaluate them, okay? If you take the history and you feel that you need to rule out ulcer disease, then you need to do endoscopy and also do gastric biopsy. And you should, in terms of non-ulcer dyspepsia or functional dyspepsia, there'll be no ulcer seen, there'll be no cancer seen. So it will be more of a normal upper GI endoscopy. If you are still not comfortable, you could do imaging studies to rule out things like gallstones, which could also have pain in the epigastric area. So, or in elderly people, it could be even ischemia, mesenteric ischemia. So you need to exclude other things. Also, during endoscopy, you could also, if you suspect that there could be some things to do with celiac disease, then you could take biopsies and send for analysis. So it depends on what. For H. pylori infection, and as we have mentioned, the H. pylori could be picked from stool antigen test. That's the cheapest what we have available. If you're in developed world, from the rare breath test, and if you've done endoscopy, why not take a biopsy and do either UDS test, which you can do on the spot, or send it for histology and use those staining which are already positive and you still, and there is no other, there's no ulcer, and you have labeled your patient as having functional dyspepsia or non-ulcer dyspepsia, then you need to eradicate the H. pylori. We have mentioned that you give medicines for 2 weeks. Symptoms persist, then put them on PPI for 4 to 8 weeks. If H, because then you don't eradicate H. pylori, you put them on PPI for 4 to 8 weeks. If symptoms persist, discontinue PPI and give them a trial of tricyclic antidepressants for 8 to 12 weeks, small dose, not high doses of depression. For amitriptyline, attempt to use anything from 6.25 to 25 milligram, depending on the patient I'm dealing with. Continue with the tricyclines for 6 months, then discontinue. But if symptoms resume or recur, then you can resume the tricyclic. If no improvement with tricyclics, then give trial of prokinetics for 4 weeks. That means you are given the PPIs, tricyclic, and they didn't respond. Then you need to try them with prokinetics. And if symptoms improve, then discontinue and repeat 4 weeks course if symptoms do recur. If symptoms diagnosis is wrong, maybe there's an organic illness you have missed. Yeah, maybe you have to do your imaging, maybe you have to check stool for giardia, things like that. There could be something, there may be some food intolerance. So you really need to reevaluate the symptoms and see if you missed the diagnosis. If you had not performed an upper GI endoscopy, then you need to perform it. And you may have to assess gastric emptying in patients with nausea and vomiting. If you have reviewed your symptoms and you still feel it is a functional dyspepsia, they're not responding to your H. pylori eradication if it's present, they're not responding to the PPI, they're not responding to the tricyclics, small dose, they're not responding to the prokinetics, then you need to involve the psychotherapy. You need to give a trial of psychotherapy. So you need to involve the psychiatrists to help you manage these patients. That's in terms of functional dyspepsia. What about irritable bowel syndrome? Irritable bowel syndrome is a functional disorder of the GIT characterized by chronic abdominal pain and altered bowel habits. We do make, we've used the Rome 4 criteria for diagnosis of IBS. In terms of the Rome 4 criteria for diagnosis of IBS, it requires that the patients have had recurrent abdominal pain on average at least 1 day per week during the previous 3 months. Not just somebody starting to have pain this week, then you say it's functional dyspepsia, no. I mean, you say it's IBS, no. It has been recurrent in the last 3 months and at least 1 day per week. And they should be associated with 2 or more of the following. The pain occurrence should be related to defecation, may be increased or unchanged by defecation. It could be associated with change in stool frequency, could be associated with change in stool form or appearance. What are the supporting symptoms? Altered stool, that means symptoms which go with the pain. Altered stool frequency, maybe too low or too high. Altered stool form. Altered stool passage, straining or urgency. mucus in the stool, and there may be an associated bloating or a subjective feeling of distension. So these things which relate to stool or tend to be there in somebody with pain related to IBS. There are four bowel patterns in IBS. There's the IBS diarrhea predominant. There's IBS constipation predominant. Then there's the IBS, which is mixed diarrhea and constipation. And then we have the unclassified. Thus, the symptoms cannot be categorized into one of the above three subtypes. The altered bowel habits in IBS could have the following characteristics. The constipation, there's variable results in complaints of hard stool. The stool may be narrow, of narrow caliber. Patients will tell you, my stool is so thin. Or there may be pain on when passing the stool. Or they may be saying that they don't go to the toilet every day. And they may be on laxatives, which may or may not be responsive. If it is the diarrhea predominant, the diarrhea, they tend to describe it as small volumes of loose stool with evacuation preceded by urgency or frequent defecation. Then there's the postprandial urgency is common also. These are the people who will tell you that or they may, whenever they eat, they want to go to the loo. When they go for a party, they have to first identify where the toilet is and whether it's clean or not before they start engaging in meals. So postprandial urgency is common, as is alteration between constipation and diarrhea. Okay, as we have said, there's a mixed pattern. Characteristically, one feature dominates in a particular patient, but significant variability exists among patients. Characteristics of abdominal pain in IBS still continue. The pain is frequently diffuse without radiation, it doesn't radiate. The commonest sites of pain include the lower abdomen, particularly the left lower abdomen. Acute episodes of sharp pain are often superimposed on a more constant dull ache. Meals may precipitate the pain, and defecation commonly improves pain but may not fully relieve it. A few patients, the pain gets worse after defecation. Pain from presumed gas pockets in the splenic flexure may masquerade as anterior chest pain or left upper quadrant abdominal pain. So you need to take a careful history. The pain may vary from mild to severe. The pain is relieved by defecation, as I've already said, though in some patients I've said the pain worsens with defecation. Emotional stress and meals may exacerbate the pain. Patients with IBS also frequently report abdominal bloating and gas production, and they tend to have flatulence or excessive belching. Now, you also need to evaluate these patients whom you suspect have got IBS. And how do you evaluate them? Look for alarm symptoms in terms of your history. Is there a history of weight loss? Evaluate them, examine them. Are they anemic? That's also an alarm symptom. If they're anemic, is it iron deficiency? That means they're losing some blood from somewhere. So now you need to evaluate their GI tract. Could there be some family history of organic illnesses like inflammatory bowel disease, celiac sprue, or colorectal cancer? Do screening tests to rule out disorders other than IBS. So the tests are to rule other diseases. IBS is a diagnosis by getting a careful history, and it's a diagnosis by exclusion. The tests are to exclude other diseases, not to diagnose IBS. So you need to do a total blood count and differential, rule out any anemia, evidence of inflammation and infection. Also do metabolic panel to evaluate metabolic disorders. Things like thyroid disease could present with GI disorders. Diabetes may present with GIT disorders. So you do need to do metabolic disorders. Also rule out dehydration, electrolyte abnormalities, in particular in patients with diarrhea. Do stool examination for oval parasites. Check for enteric pathogens. Do leukocytes in the stool, Clostridium difficile toxin, and also include Giardia antigen. Hydrogen breath testing could exclude bacterial overgrowth in patients with diarrhea, particularly the so-called SIBO. Also screen for lactose and fructose intolerance. Tissue transglutaminase antibody testing and small bowel biopsy in IBS, diarrhea predominant, should be done to exclude celiac disease. Also, as already mentioned, thyroid function test should be done to exclude thyroid disease. Okay, and also serum calcium should be done to exclude, to screen for hyperparathyroidism. ESR and C-reactive protein to screen for evidence of inflammation in the GI tract. How do you manage IBS? Here you'd need to do psychological support, discuss with the patients, counsel them, and if need be, you may have to get some counselors to help you. Dietary measures need to be considered. Check on their lactose intolerance. Could they be having celiac disease? Maybe they're taking too much of vegetables, giving them gas and bloating, and or they're not taking adequate fluids and or roughages. So you need to do dietary counseling and measures and take a good history and intervene. Pharmacological treatment may be of value. If they are diarrhea predominant, sometimes you may have to use antimotility drugs like Imodium. If they are constipation predominant, maybe you may have to give them the bulk, increased fiber in terms of laxative to improve the bulk of the stool. If there's a lot of pain, then you may have to give them maybe antispasmodic. Peppermint oil is also useful in those type of patients. And if there is some or a bit of there tends to be some input from the brain in terms of IBS. So in this case, you may use low-dose tricyclic antidepressants, particularly if they are diarrhea predominant, because that would be quite useful. So with that one, I think we'll call it a day there and entertain questions. So if we have questions. Are there questions? Let me see. Chat. Diet in terms of peptic ulcer disease. No, we don't really restrict that in peptic ulcer disease. Let them eat anything, and so long as it does not, even if somebody has peptic ulcer disease and they are comfortable with spices, they are not getting more pain, let them eat. So really, the advice is patients to avoid foods which trigger their pain or make their pain worse. But this issue of particular diet, that is not really practiced these days, okay? But in general, traditionally, there are those who try to avoid spices. Maybe if it is particular functional dyspepsia is where diet comes a lot, so you really need to take a good dietary history and advise them. Then Faith is why are we checking for thyroid disease? And I've already said, in thyroid disease, patient with thyroid disease, even last week I had a patient with thyroid disease who presented to me with constipation. So was referred to me for me to do a colonoscopy because this patient has got intractable constipation. And routinely I do thyroid function tests, I do calcium levels, I do all this. And actually, to my surprise, the patient had hypothyroidism. So though we did colonoscopy, in fact, we have not done colonoscopy, so we have decided we give thyroxine supplement first and see how the patient responds before we go ahead. If they have thyrotoxicosis, then they may be having frequent diarrhea, and you may just think that it is IBS or something like that. So we tend to do, that's the reason we do thyroid disease. Hyperparathyroidism, calcium, high levels of calcium tend to give you constipation also. So if you find an organic disease, the idea is to rule an organic disease. So if you find an organic disease, then you treat it, and that will be the end of the story. Then Joyce is saying, is there any specific investigation for IBS, or is it IBS is a diagnosis by exclusion. You do the test to exclude other diseases. Then you remain with your IBS, which you had made a diagnosis from the symptomatology. Okay? It's mostly diagnosed by, yeah, that's correct. So you have said the correct thing. Okay? I think those are the only questions. If there is no other question, then I must thank your class rep. It's been very helpful to me today. I had some blunders with my internet. There's something which at press, so I was my computer was not accessing, and as I was about to leave.